You're watching PCTV Channel 17, proudly serving the Port Clinton City School District community. The following is a production of the Port Clinton High School Digital Media class.
Welcome to Time for Health. I'm your host, Rachel Fall, and we're very glad you've joined us. We hope you gained something from the program that helps you and your loved ones. We want to arm everyone with as much information as possible so we can all make good choices. And this is not to take the place of regular medical care, so be sure to include your healthcare provider in on your plans and your conversations. And today, our guest is Dr. Rashid, and we're talking about prostate cancer. And I joke every episode that I know just enough to be dangerous, and of all the topics, I'm not qualified. So. Thank you for being here. You are a very, very busy individual, so I appreciate your time.
Thank you, Rachel. It's great to be here.
All right, good deal. So, prostate cancer. Talk a little bit about what it is, how long has it been around, when did it really get discovered as its own separate kind of cancer?
So, prostate cancer is the most common malignancy diagnosed in the United States. The incidence of prostate cancer is about 225,000 per year, whereas the mortality from prostate cancer is about 27,500 deaths per year.
How does that compare to other,
So in terms of mortality, it's only second to lung cancer in men.
Okay.
Now, the incidence of prostate cancer has increased since the advent of PSA screening.
Okay.
And if you look at the incidence of prostate cancer in the United States versus the rest of the world, you'll find some staggering differences. For example, in the United States, the incidence of prostate cancer amongst Caucasians is approximately 101 per 100,000 patients, whereas the number is 65 for Canada. It's about 50 for Germany and Sweden. It's about 12 for Italy. And not to say that there might not be any dietary differences between Caucasians living in Germany or Sweden or Italy and the United States, but I don't think the genetics are that much different. Okay. So I think the overall difference in the incidence of prostate cancer in the United States is primarily accounted for by the increased PSA screening that we have.
Okay. So because we test for it more, we're going to see it.
We are diagnosing it more. We are diagnosing it almost twice as much as Canadians, and almost 10 times as much as Italians.
Okay. And you said PSA. I do know that. That's a blood test, right?
It is. Mm-hmm.
So it's actually just a blood draw that tests.
Exactly. So PSA is it's a chemical substance that is produced both by normal prostatic tissue as well as prostate cancer. Okay. And elevations in PSA are often seen in the most common variant of prostate cancer early in the disease. Okay. So you could use PSA to screen for prostate cancer.
Okay. Doesn't necessarily, if you have a high PSA, does not necessarily.
No, it does not. The likelihood of being diagnosed with prostate cancer for PSA between 4 and 10 is about 25%. And 4 is generally considered the cutoff for referral for a biopsy. Okay. In other words, if the PSA is only modestly increased, there's a greater chance that the patient does not have prostate cancer than otherwise. Okay. Of course, with higher PSA, the likelihood of getting diagnosed with prostate cancer also increases.
Okay. So it's not particularly black and white, easy for us to figure out on our own.
No, a high PSA does not mean prostate cancer. Okay. I think that's the most important thing. There are a lot of other things that can cause increase in PSA. Prostatic infection can cause increase in PSA. Riding a bicycle just 48 hours prior to the PSA test can transiently increase the PSA. Okay. Sex before PSA can
Increase it.
can
Okay.
cause a slight falls at high value.
Okay. Are there?
And there are certain drugs that can also cause the PSA to go down. So
Oh, okay. That's why we come to see a doctor to
Right.
figure out. Okay. Risk factors. Are there certain populations that are more at risk, or if you have a family history, talk a little bit about that.
absolutely. So I always explain this to my patients that the single most important risk factor for prostate cancer is age. There is no other cancer that has a stronger association with age than prostate cancer.
Okay.
If you look at the data from autopsies, about 2 to 8% of individuals between the age of 20 to 30 might harbor occult prostate cancer,
Okay.
whereas the number is about 43 to 83% in
wow.
men between the age 70 to 80.
Okay.
So the older we get, the more likely we are to be harboring prostate cancer.
And
So
there's
age-
nothing we can do about our age. So that's a
There's-
factor that's just
It's a
there.
fact of life. It's a
Okay.
fact of life. Often at times patients ask me, doctor, what caused my prostate cancer? And I tell them age. Age is the strongest risk factor.
Okay.
After age, I would say family history.
Okay.
Individuals who have one first-degree relative who was diagnosed with prostate cancer have a twofold increased risk of getting diagnosed with prostate cancer themselves.
And what's a first degree relative?
A father or a brother.
Okay.
Can also be a son, but in this case it means father or a brother.
Father or brother.
Father or brother.
Okay.
If they have two first-degree relatives, then the risk is increased 5 times.
Okay.
And if they have 3 first-degree relatives, then the risk is increased 11 times.
Oh, okay.
Okay, so family history is very important.
Okay.
And I would say the third risk factor is ethnicity.
Okay.
The overall incidence of prostate cancer in African Americans per 100,000 people over the age of 70 is about 1,600, whereas this figure is about 1,000 for Caucasians and about 700 for Asians.
Okay.
So, and not only that, African Americans also tend to get diagnosed with prostate cancer at an earlier age, and there's also a tendency to get diagnosed at a more advanced stage.
Oh, okay.
So there are triple threats
Okay.
in that patient population.
Okay, so those are the top 3. You said family history, first degree relative of prostate cancer. Is there any, I don't know if you know this off the top of your head, but other kinds of cancer? A mother had breast cancer, a father had skin cancer, or is there?
Yes, absolutely. So prostate cancer has a well-defined association with the BRCA genes, especially BRCA2. Now, BRCA2 is and BRCA1, they're both generally understood to be breast cancer genes.
Right, that's right.
So mutations in BRCA1 and 2
Okay.
confer an increased risk to develop breast cancer. But as we are increasingly realizing, not just breast cancer, but also prostate cancer and pancreatic cancer and melanoma and certain other cancers as
Okay.
well. And then there is an association with so genome-wide studies have shown an association between certain single nucleotide polymorphisms. Where does that take us? I don't know that yet because such tests are not commercially available. And then there's an association with HOXB13, which is another gene. So we understand some of the genetics of prostate cancer. We don't completely understand
Okay.
the full
All of
picture.
it.
So what we recommend whenever we see a patient with personal history of prostate cancer and family history of other cancers that are out of the ordinary, especially if there's a family history of breast and pancreatic cancer,
Okay.
then we refer them to our genetic counselors.
Okay.
And then what they do is they'll plot the family history and discuss the implications of genetic testing with the patients.
Wow.
And if there is a mutually agreed decision, then genetic tests are ordered.
Okay.
So that's.
It's a moving target.
It is a moving target.
Constantly.
It is.
I mean, and that's the blessing of research.
Yes.
So in May 2015, as we sit here, this is kind of what it looks like, but research is going on all the time, genetic testing is going on all the time,
Yes.
and it changes all the time.
Yes.
That's why you're here, because it's kind of changed over the years.
It is.
Okay. So risk factors, symptoms. What might be some symptoms?
So the earliest symptoms are due to enlargement of the prostate gland.
Okay.
Patients will typically report difficulty with urination, a weak stream,
Okay.
Inability to empty the bladder completely. It's interesting because a lot of patients will not tell you, "Hey doc, I can't empty my bladder completely." I have noticed that a lot of patients just simply say, "No, I don't have any problem." But once you ask them how many times you get up during the night to go to the bathroom, they say, "Oh, only 2 to 3 times." Well, you're not supposed
That's
to go to
more
the
than
bathroom,
normal.
right? Yeah, so that's not normal, but it becomes a normal for them because these symptoms evolve slowly over time.
Gotcha.
So inability to empty the bladder completely, difficulty with urination, weak stream. In late stages, there may be prostatic pain,
Okay.
pain in the pelvis, there may be blood in the urine, and of course if the cancer metastasizes to other organs, then there will be symptoms related to that organ.
Okay.
Prostate cancer typically metastasizes to the bones. So bone symptoms like bone pain,
Okay.
that can't be explained by something else,
Okay.
is one of the early symptoms of metastatic prostate cancer. Prostate cancer, while typically it metastasizes to the bones, it can metastasize anywhere in the body.
And that's just the way it spreads.
Yes.
Typically it spreads that way, but
Typically it spreads to the bones,
Okay.
but it can metastasize to the liver, the lungs, basically anywhere in the body, and compromise the function of that organ.
okay. So the rates are kind of a little bit high around here, but part of that is because we're testing a lot more for it and finding a lot
You're right.
more for it
Yes,
of it.
right.
Okay. And we talked about risk factors, symptoms. How is it diagnosed? There's screenings and then there's diagnosis. How does all that work?
So it's diagnosed in one of two ways. It's either diagnosed through screening or because of symptoms.
Okay.
So we just discussed what the symptoms are. Patients will present to their primary care physicians with these symptoms. Then a PSA test is done,
Okay.
which is a blood test. If the PSA is significantly elevated, if it's more than 7, then the patients are referred to urology for biopsy of the prostate gland.
Okay.
If the PSA is only mildly elevated, between 4 and 7, typically the primary care physician will ask the patient to come back after several weeks to have it drawn again
Okay.
to see if it's
Okay.
consistent.
Okay.
If there are clinical symptoms of infection of the prostate gland, then patients are treated for it empirically. Patients are advised not to ride a bicycle or have sex prior to
Okay.
PSA testing.
Okay.
And if it's still high, then they're referred for
To the next
an
step.
ultrasound guided biopsy.
Okay. All right. We're going to take a quick break and we're going to be right back and talk some more about prostate cancer. Prostate cancer. We talked a little bit about risk factors and some of the symptoms, and someone will either present to a physician for a screening or because they have symptoms. That's usually how people are diagnosed. Talk about the screening a little bit. The recommendations have changed over the years. Where can somebody go to get a good idea of what those recommendations are, or do they just need to go to their doctor?
That's a very good question. So I'll preface this by saying that when I was a resident in New York in the 90s, we were screening everybody over the age of 50 with a PSA test. And I guess that was the standard. Since then, we have realized that there's moderate certainty that screening with PSA carries more harm than good.
Okay.
So we no longer have this blanket recommendation for PSA screening.
If you're over 50.
If you're over 50, get a PSA done every year. We no longer have that blanket recommendation.
Okay.
If you look at the guidelines from international societies, most of them do not recommend screening for men who are at average risk for developing prostate cancer. Here in the United States Preventive Services Task Force does not recommend screening with PSA for men who are at average risk of developing prostate cancer.
Okay.
Guidelines from American Cancer Society and the American Urological Association emphasize the role of informed decision making. This is what I do in my practice. Patients who are at a significantly increased risk of prostate cancer, such as African Americans or individuals with a strong family history of prostate cancer, I initiate discussion about screening with them beginning age 40.
Okay.
Okay. And if a decision is made, a mutual decision is made between the patient and the physician to screen, then I typically order a PSA every year or every second or third year.
Okay.
Okay. And I refer them to urology if the PSA is greater than 7 on the time of first test, or I refer them to urology if the PSA is consistently more than 4.
Okay.
Okay. For men who are at average risk for developing prostate cancer, and that is men between the ages 50 to 70.
Okay.
Okay, and I say 70 because over the age of 70, the average life expectancy starts shrinking down, so it's
Sure.
not more than 10 years. There isn't much proof that screening at that stage would lead to longevity.
Okay.
So in the age group between 50 and 70, we have this conversation that, look, we might diagnose prostate cancer at an earlier stage if we do PSA screening, but there will be consequences. There will be psychological consequences.
Sure.
You'll have to undergo a biopsy, and if we diagnosed a prostate cancer, you'll be recommended treatment, and treatment might be surgery, might be radiation therapy, and there could be side effects from the treatment. Whereas, if we don't screen, there's a pretty good chance that you could have years before the prostate cancer would cause any symptoms.
Okay.
So if after this discussion a patient prefers to undergo a screening, then in this age group, I'll do a PSA every year to once every 2 to 3 years.
Okay.
So this decision is based on an always ongoing conversation with the
Okay.
patients. Now, who should have this discussion?
Right.
Most of the time, patients are not seeing a medical oncologist.
Right.
It's their primary care physicians.
Okay.
So the primary care physicians represent the hub for the management of any cancer, especially prostate cancer. For the most part, it's the PCPs that are having this conversation. But everybody's got a role to play. So when a
Right.
patient gets referred to urology for a biopsy, the urologist will also explain, hey, you don't have any symptoms, your PSA is only borderline elevated, do you want to continue ongoing surveillance, or do you want a biopsy? And they'll explain the consequences of a biopsy
Right.
and the complications of a biopsy. We oncologists typically get to see these patients when they've already been diagnosed with prostate cancer.
Okay.
In fact, for the most part, we see patients once the prostate cancer has escaped the confines of the prostate gland and has spread to other organs.
Okay. I heard once, again, I know just enough to be dangerous, if prostate cancer is diagnosed at a younger age, it tends to be more of the aggressive kind of cancer, but if it's diagnosed at a later age, it is not as aggressive, and it's not going to be the cause of their death more than likely.
So, from our observation in African Americans, that appears to be the case.
Okay.
Men that get diagnosed with prostate cancer at an earlier age, they do tend to have a more aggressive variant of the cancer.
Okay.
And often at times the disease is more advanced at the time of presentation.
Okay.
So there is some truth to that.
Okay. So the screening recommendations really is a conversation with your primary care physician, because
It is.
you used to, the common practice was screen everybody over the age of 50. Now that's
It does not apply because we don't have evidence. We don't have strong evidence that screening is more beneficial than harmful.
Because, like you said, you have to understand the consequences
Yes.
of what a biopsy involves, what
Right.
surgery or treatment will
A
involve.
person could be totally fine and asymptomatic, and all of a sudden he's got a cancer diagnosis now. So that just upsets their whole life.
Right.
They might have been diagnosed a few years down the road. They could have had a few years of stress-free life.
Right.
So those are some of the consequences.
That's why it's a conversation.
And
with
screening has not consistently shown to be associated with improvement in longevity. So the main reason is that prostate cancer is usually diagnosed in the elderly, right, in men over the age of 70. Yes, there are outlying cases where cancer is diagnosed even in the 40s, and yes, that's the bad kind of prostate cancer. But by far, prostate cancer is a disease of the elderly. So in the elderly, there are a lot of other competing comorbidities.
Right.
And it's hard to prolong longevity by just going after only one of them.
When
which is
there
the
might be heart issues or diabetes issues.
There usually are.
Yeah.
In the 70s, there's high blood pressure, diabetes, heart disease, some other cancer, COPD, so forth. So there are lots of other competing comorbidities. So taking away just one of them does not change the overall picture. And when I say taking away comes at a price.
Right.
Starting from biopsy, there could be complications from the biopsy itself. There's pain associated with biopsy,
Sure.
but if you get diagnosed with the cancer, then
there's an
what follows
obligation
is
to treatment.
there's an obligation to treatment.
And we have a few minutes left, so can you talk a little bit about different treatments? Is it usually radiation or
Sure.
implants?
Right. So prostate cancer is a hormone-driven cancer. It is driven by male hormones. So what the mainstay of metastatic prostate cancer, once that escaped the confines of the prostate gland, is deprivation of the cancer of male hormones. So you block the effects of male hormones on the cancer cells. They regress, they shrink, and they go away. But over time, they learn to grow independently in spite of androgen deprivation.
Okay.
As far as the treatment for organ-confined prostate cancer is concerned, typically we divide our patients in 3 categories: low risk, intermediate risk, or high risk.
Okay.
There is also an entity that's called very low risk and also an entity called very high risk.
Okay.
Low risk patients, if low and intermediate risk patients, if their expected survival is less than 10 years, then they can be observed without active treatment.
Okay.
Treatment can involve external beam radiation therapy, or radioactive seed implants, or radical prostatectomy.
Okay.
And radical prostatectomy can be done, is increasingly being done through laparoscopic or robotic approaches.
Okay.
So radiation, surgery, and by radiation I mean both external beam and radioactive seed implants. These are the mainstay of the treatment of prostate cancer that is confined to the prostate gland.
Okay.
In high-risk patients, radiation therapy is often supplemented with androgen deprivation therapy.
Okay.
And this can range anywhere from 6 months to up to 2 to 3 years.
Okay. So radiation, and is that chemotherapy or?
No, it's treatment with medicines that block the production of male hormones.
Okay.
But that's mainly for patients who have at least intermediate risk prostate cancer.
Okay. So there are treatments, and lots of conversations I can imagine are had, because at that point they would come probably see.
Right. Once they're diagnosed, they usually get to see a urologist or a medical oncologist.
Okay. And then they have more conversations.
And then they have
about-
more conversations. Right.
So it's all about, like I say in the beginning, make sure you include your healthcare provider in on your plans, because that's kind of where it starts. Like you said, it's the hub.
Yes.
And that's kind of where it
Right.
has to start. Any final thoughts? Anything that we didn't cover, or things that I really want people to know or wish they would ask, or?
Know your risk factors.
Okay.
I think that's the most important thing. I think there isn't one size fits all recommendation for the general population.
Okay.
If you have strong family history or belong to certain ethnic groups where the risk of prostate cancer is high, I think it's important to discuss this with your primary care physician early on.
Okay.
I think I believe that in certain populations there is a value to PSA screening.
Okay. That's knowing your risk factors and talking with, keeping on top of it, talking
Staying
to your
on top of
physician.
it.
Okay. Awesome. Thank you very much. All right.
Thank you. Thanks for having me.
Sure. We're going to take another break, and we'll be right back.
Okay.
Thank Dr. Rashid for being our guest today, talking about prostate cancer, a moving target, a changing topic, lots of research going on, which is great, but it causes things to change from time to time. So like I said in the beginning of the show, that's why you need to include your healthcare provider in on your plans and your conversation. So I hope you learned something that maybe you can use or somebody that you know could use. If you ever have feedback about a program or a suggestion for a future episode, please let us know by sending a note to Time for Health, 615 Fulton Street, Port Clinton, Ohio, 43452. Or you can email Carla Pelz at the high school, cpelz@pccsd-k12.net. So again, think about some of the things we talked about, knowing your risk factors, risks and benefits involved, and most importantly, the conversation with your physicians, whether it's an oncologist, urologist, your family doctor. And until we meet again, I encourage you to make time for health.